This last lesson of section 1 begins our discussion on the pathophysiology of BMS, and it is worth noting that the mechanism of disease is not completely understood, and hypotheses to explain this are popping up every now and then. It is still a developing arena of scientific research, and all I can say confidently for now is that we still do not know why BMS occurs. Now, that being said, there have been very impressive developments in recent years to suggest the cause, but it's still difficult to pinpoint one particular problem. And it seems factors that have been suggested to play a role may actually be acting in combination. In this lesson, I am going to highlight 5 associations with BMS and talk briefly on their pathophysiology and how any of them may influence the development of the condition. These 5 associations will be the association with parafunctional habits, association with taste perception, postmenopausal and perimenopausal association, association with temporomandibular disorders and dysfunction of the masticatory apparatus, and finally, the microbiological association with the Helicobacter pylori organism. Before we get into action, however, let me say that there has been no association of BMS with oral cancer development, and it is very important to talk to your patients about this and to reassure them in order to relieve the anxiety, as this will be an important part of the management process. There are some clearly outlined and documented associations of BMS, and these associations may either be triggers or factors and certain oral behaviors that are thought to initiate or exacerbate the symptoms of this condition. In fact, very often, patients link such triggering events to their symptoms, and this becomes very important during the management process. Much more important, however, though, are patients who may not be aware of such triggering behaviors and will constantly continue performing these habits, which in turn worsens their symptoms unbeknownst to them. It is therefore our duty to take a detailed history specifically asking about such events or triggers. The very first association to consider is parafunctional habits. Now, some of these habits include tongue biting, tongue thrusting, bruxism, clenching, and biting of other oral mucosa sites. These may or may not be consciously performed, and such repetitive biting activities, especially of the tongue, results in tissue microtrauma, and this is thought to start or perpetuate neuropathic changes submucosally and thereby predisposing these patients to BMS. In one study, parafunctional habits was present in over 60% of patients with BMS, and a reduction of symptoms may occur following habit control, lubrication, and wearing tongue protectors and occlusal splints. One thing to note is that these habits are particularly prevalent in patients with anxiety, and this may be one of the reasons why anxiety and BMS are closely associated, as we saw in previous lesson. But as to whether the anxiety followed the BMS or vice versa, well, it's a chicken or egg situation because, for instance, patients with oral burning pain frequently are cancerophobic. That is, they have extreme fear that their condition is cancer. And this is one source of their tremendously high levels of anxiety. On the other hand, anxiety developing from an unknown cause may lead to frequent repetitive parafunctional habits, which will lead to chronic low-grade trauma with eventual progression to BMS. So it is a chicken or egg situation, but nevertheless, the association is still strong, and managing anxiety and these parafunctional habits is an important step in the overall management of BMS. We've mentioned briefly how some of the parafunctional habits may be managed, and we listed habit control, occlusal splints, and tongue protector. Now, what is a tongue protector, as some of you may be asking? Well, here it is. So here is the tongue without the tongue protector, and here is the tongue protector coming on. So without a protector, with a protector. So what the protector is a transparent low density sheet of polyethylene material that is worn 3 times daily for about 15 to 20 minutes each time, and for about 2 to 3 months long. As you can see, it covers the whole of the anterior 2/3 of the tongue, which is the part most likely to be traumatized, and it's also the part most likely to be affected by BMS. Now, obviously, this is a schematic diagram, but shouldn't be difficult to conceptualize. Here is another demonstration of a tongue protector. Remember, it is worn for 15 to 20 minutes and for 2 to 3 months, but then the wearing time can always be extended depending on the patients. Let's move on now to talk about the taste association. Now, in the very first lesson, we looked at the IASP's definition for BMS, and I pointed out that at least 2/3 of BMS patients, if not more, have some abnormal taste perception and dry mouth in addition to their oral pain. While majority of these may only be subjective, actual dysgeusia and xerostomia could be present in a few of the patients because it turns out that as part of the neuropathogenesis of BMS, the integrity of the chorda tympani nerve and the density of the fungiform taste papillae on the tongue may actually play a role. For now, hold on to this thought and let's first review some local normal anatomy regarding this. Now, just to orient ourselves, this is the facial nerve coursing through the temporal bone and exiting via the stylomastoid foramen. Here is its geniculate ganglion, and throughout its course, the facial nerve gives off several branches, amongst them they share sensory, motor, and autonomic functions. The terminal branches will be the filaments innervating the muscles of facial expression after dissecting through the substance of the parotid gland, which is located back here. The branch we are concerned with, however, is the chorda tympani nerve, which exits from the base of the skull through the pituotympanic fissure, which is here. The nerve then enters the infratemporal fossa, which is identified by this blue area. During its anterior-inferior course through the infratemporal fossa, the chorda tympani is joined, or rather joins the lingual nerve, which is coming from the trigeminal system, specifically the mandibular V3 branch. As such, the chorda tympani basically distributes to the same tongue areas as the lingual nerve, that is the anterior 2/3 of the tongue, except that whereas the lingual nerve transmits common general sensations like pain, temperature, and touch, the chorda tympani transmits taste sensations from the anterior 2/3 of the tongue. So in other words, both lingual nerve and chorda tympani nerve innervates the fungiform papillum. The chorda tympani nerve sensing gustatory information from the taste buds, and the lingual nerve sensing pain, temperature, and touch from the intervening epithelium. This information will be helpful in understanding some aspects of the BMS pathophysiology, basically moving forward. Now, one more thing. The chorda tympani nerve also sends preganglionic secretomotor messages to the submandibular ganglion, which then go to the submandibular, sublingual, and minor salivary glands on the same side. This figure should further demonstrate, at least in full, the similar course of both nerves, that is the lingual and the chorda tympani taste fibers. For orientation, here are the lips, here are the upper and lower jaws, the submandibular and sublingual glands with the ganglion above, and here is the tongue with the taste buds within the epithelium of the fungiform papillae. And notice that they are limited to the anterior 2/3 of the tongue. The posterior 1/3 is basically taken care of by the glossopharyngeal nerve. Here are our nerves, the lingual nerve going to the epithelium and the chorda tympani to the fungiform papillae taste buds. And here are the salivary autonomics for the secretomotor function. Take particular note of the fact that both common sensation and taste sensation are in close proximity and oftentimes are actually bundled together within the lingual nerve to travel as one. Both sensations are regulated and function at equilibrium under normal circumstances. This means that when one of both fibers undergoes some chronic pathological change, the other becomes hyperfunctional, that is, hyperfunctional. In general, however, it is known that the chorda tympani taste fibers exert an overall inhibitory control on the mucosal somatosensory system, that is, on the trigeminal lingual nerve system. In the case of BMS, it is thought that neurodegenerative changes in the chorda tympani nerve for any reason results in heightened lingual nerve transmission, and thereby accentuating common sensations like touch, pain, and temperature. This disinhibition results in symptoms such as phantom pain, allodynia, hyperalgesia, and so on, and these are characteristics of BMS. The direct clinical effect of the degeneration of the chorda tympani will be taste phantoms or dysgeusia, and also because the salivary autonomics are within the chorda tympani, they also get degenerated and a feeling of oral dryness occurs. These are all classic findings in BMS and are specifically stated in the definition by the IASP and have also led to the so-called BMS triad comprising oral burning pain, dysgeusia, and xerostomia. Now note that this neural degeneration of the chorda tympani doesn't have to be bilateral at all, because it's been reported that even one-sided hypofunction of this nerve may be enough to cause diffuse burning pain way past the confines of the affected nerve region. This finding has suggested that there may also be a centrally mediated mechanism for the somatosensory disinhibition. This pathogenesis just described is supported by the following facts. Firstly, BMS pain is often relieved by eating, because by tasting and eating food, the residual taste fibers get activated, and by doing so, they temporarily re-establish the sensory equilibrium by inhibiting the lingual nerve trigeminal system. Secondly, BMS is most common on the anterior two-thirds of the tongue, that is the site with the largest number of taste buds and the site innervated by both the chorda tympani and the lingual nerves. The third point is that BMS is high in supertasters. I will explain this in a second. Lastly, the simultaneous occurrence of BMS and atypical odontalgia in some patients. Now, atypical odontalgia is also thought to have similar taste type of function as part of its pathogenesis. This next part of the taste pathogenesis will look at the density of fungiform papillae and how it relates to BMS development. Let me begin by saying that there are two main groups of people in this world, non-tasters and tasters. Tasters can further be grouped into medium tasters and super tasters, and it all has to do with the genetic ability to taste this chemical, that is 6N-propylthiouracil, a chemical that is bland to non-tasters but bitter to tasters. While medium tasters perceive less of the taste, super tasters have an intense bitter perception. Super tasters have the densest of fungiform papillae, and these papillae are the predominant taste bud containing papillae of the anterior two-thirds of the tongue. So with this information, we can infer that super tasters will have more taste fibers than an average taster, and therefore a relatively higher level of inhibitory influence on the lingual nerve trigeminal sensory system. This means that any loss of taste fibers will have a greater disinhibitory toll on super tasters than average tasters, hence resulting in a greater incidence of oral burning pain in such individuals. And it's been shown that the intensity of pain correlates well with the density of these papillae. These individuals are at risk for taste allodynia, especially to food substances such as chili and sometimes citrus foods. Next association to talk about is menopause. It has been documented that by far, till date, BMS occurs more in females of postmenopausal age, up to about 40%, and is rare before 30 years of age. Postmenopausal women are also more likely to have other burning pain conditions like vulvodynia, and hormone alterations in this population have been blamed to induce these neuropathic mechanisms. The relative deficiency of estrogen among this population of women is thought to decrease the sensitivity of taste buds and also reduce salivary function, with the resultant dysgeusia and xerostomia, hence bringing us back to the BMS triad, that is oral burning pain, dysgeusia, and xerostomia. The role of these hormones, however, in BMS is not strongly supported anymore because hormone replacement therapies in these patients really are not very effective. Next up is the association with temporomandibular disease. In one observational study, about two-thirds of BMS patients showed symptoms and signs of concomitant temporomandibular disorder. One hypothesis to explain this is that the probable deficiency within the dopaminergic system allows the trigeminal system to become upregulated and hyperfunctional. Since the trigeminal system is a dual system that is sensory and motor, the sensory hyperfunctionality results in BMS symptoms, and the motor hyperfunctionality results in temporomandibular disorder with myofascial pain and internal derangements of the joint. Another possible reason for the TM disorder could be because of the high rate of parafunctional habits within these patients, with these repetitive activities like clenching, bruxism, putting stress on the masticatory apparatus. A more interesting association though is with the Helicobacter pylori microbe, an organism that most of us know to be highly associated with gastric ulcers, gastritis, and even stomach cancer. H. pylori has also been associated with oral lesions like atrophic glossitis, erythema migrans or geographic tongue, and burning mouth syndrome. I will detail out these other associations in their respective lectures, and you may find these in the lecture catalog on this website. With regards to BMS, it has been found out that BMS was higher in patients suffering from gastritis and vice versa. with the levels of H. pylori being elevated in BMS patients when compared to controls. In one study, over half of BMS patients suffered from gastritis. Now, studies regarding this association are still in their infancy, and no further conclusions can be made at this time. This brings us to the end of the lesson and of the section. Take 5 and move on to the next section. Do not forget to mark this lesson as complete.